it goes off again, okay? All right. So those are our subcategories. And then after xanthine derivatives, see that next purple section? Like if you look on page 365, your next little branch would be anti-asthma drugs. And those are your only two subcategories underneath that big umbrella of lower airway drugs. All right, so now I'm gonna go to my PowerPoint, and most of what I said is going to start. So for anti-asthma drugs, the biggest thing is steroids, inhaled corticosteroids. Everybody say, we use inhaled corticosteroids for asthma.
Inhaled corticosteroids for asthma.
Okay, so they are going to be, so steroids in general, we haven't learned about steroids either, but steroids also, who's ever gotten a steroid shot when they had a sinus infection or something?
Oh, yeah.
Did you feel like on top of the world?
Yeah.
Like, did you feel like you could clean your house and you're like, yeah. They make you feel like $1,000,000, but they also wreak havoc on your body if you take them continuously. Yes. So that's why, steroids, all steroids are different. You have intranasal steroids and you have inhaled corticosteroids and you have steroids that you take systemically like pills, and then you have shots, okay? So you have all these different forms of steroids, but at the end of the day, they make you feel like they open everything up and you can breathe and you have energy and you just feel lovely. But they're not so great for your bones. They're not so great for your skin. They're not so great for growth in children. They stunt growth in children. So when we're administering all of these other medications that we're fixing to talk about under that anti-asthma section, they are forms of steroids, okay? So obviously they're needed, right? Obviously they're needed because they can't breathe. But as nurses, there's things we're going to have to monitor when they're taking these medications. So orally, you should not, unless you have a disease process that warrants it. Orally, you should not be on steroids for a very, very, very long time. Unless your disease process you have to have them. You shouldn't be on them for a really long time. With inhaled corticosteroids, when you're inhaling it with a, whatever it's called, thank you, inhaler or intranasally, we expect for our patients to be on these for a more long term, okay? We do expect because they target those specific sites of the lungs rather than the whole systemic body. So if your patient is having a major flare-up, they are going to be on oral steroids, but we're going to taper them off of those as soon as we can. Unless their disease process is at the very end. If you have end-stage COPD, if your patient has end-stage COPD, and they absolutely cannot breathe without oral steroids, then they're going to take them for the rest of their life. That's not something for you to decide. What you need to know is that we taper off of steroids and that we give inhaled corticosteroids for patients for anti-asthma or anti-COPD. We give those inhaled corticosteroids. Steroids end with SONE, because they make you feel like you're in the zone with the S, not a Z, with the S. Okay. They also will sometimes end in NIDE. You see all those endings?
Oh.
All right. Underneath there, do you see ICS-LABA? Does anybody want to take a guess what those initials stand for? Nobody. Inhaled corticosteroids Yes, so those are combination drugs. Those are inhaled corticosteroids with some drugs from the first class that we talked about. Those will often be placed together in inhalers to give your patient a longer acting relief, okay? None of those are emergent drugs. None of the inhaled corticosteroids or these combination drugs. The only ones that are immediate are those first bronchodilators that we talked about. And then we have two other subclasses, and they work differently in the body. They're called mast cell stabilizers and leukotriene modifiers and immunodilators. So we talked about, I'm not going to jump up and down on these, but just know that there's other drugs that work. I'll probably pull out a few like Singulair. I'm sure y'all have heard of Singulair, and Dalarest. Those are the two most common drugs in that drug class. And what they are, they're oral medications. And so remember when we talked about histamines and stuff, and we talked about our body is having a response that it really shouldn't necessarily have. Sometimes the same is true in asthma. The body is like overreacting to environmental stimuli, and these drugs kind of work from that. They don't immediately work like bronchodilators, but they kind of say like, hold on, chill out, body. You don't need to get so excited about that pollen that's in the air. Mm-hmm. So it kind of stabilizes those immune type responses. So that's their mechanism of action, and that's how they work. So at the end of the day, the stuff that I'm really going to need y'all to take home is what you're going to do as a nurse, how you're going to assess your patients, how do we know if our drugs are working, which ones are long acting and which ones are short acting. Those are the things that I need you to take from this chapter of pharmacology with you to take care of your patients. So I am going to like speed through this PowerPoint. Everybody feels good? Feels okay? What's up?
Did you say only one was
the two common ones are those acute symptoms, yes. So when we go through this, I'll underline and point out those. Okay. But acute symptoms are going to be those short acting.
And the cholinergic.
Yes, and the cholinergic, because they're going to give an immediate. And then you have your long acting ones that are not going to act quickly. They're still going to bronchodilate, but they're going to do it over time. All right, so I did this one already. Did this already. That looks fun. All right. So xanthine derivatives. I want to touch on this again. They're contraindicated in patients with seizure disorders and uncontrolled arrhythmias. They're used cautiously in patients with cardiac disease, hypoxemia, hypertension, congestive heart failure. They're used cautiously during pregnancy and lactation. They interact with all of this stuff. You see, barbiturates, charcoal, hydantoins, ketoconazole, rifampin, nicotine, adrenergic agents, isoniazid, loop diuretics. It's a whole bunch of stuff that they interfere with. Look, and it's still going. Allopurinol, beta blockers, calcium channel blockers. Just know that they interfere. They cause a lot of drug-drug interactions, a lot. So if you see xanthine derivatives, which end in what? Remember?
Line.
Pheline, like P-H-I-L-I-N-E, pheline.
Wow. I just saw the word line at the end, and I think of X's made with two lines.
Hey, whatever works. That's what y'all got to do. Y'all got to put stuff together even if it doesn't make any sense. And remember they had that narrow therapeutic range that I wanted y'all to know about. All right, and then that anti-asthma drugs, this was the new subcategory, if we're making a new subcategory, they're given by inhalation, and they decrease the inflammatory process of the airways. Remember, when you get a steroid shot, it's because you have inflammation. If you get a shot in your knee, it's because your knee's inflamed. So they decrease that inflammation. Excuse me. They're used in the management and prophylactic treatment of inflammation associated with chronic asthma, allergic rhinitis, or polyps. So these are more chronic. If I gave you a question and I said, Your patient is a newly diagnosed asthmatic. The nurse anticipates he or she may be placed on blank. Would we immediately place these newly diagnosed patients on inhaled corticosteroids? No, we got to gather more information, and we're going to talk about gathering more information in a little bit. So we'll talk about that in a second. So remember I told you that overall steroids aren't really good for your body. Throat irritation, hoarseness, fungal infections of the mouth and throat, a lot of different things can go on. But these medications are given, they're being inhaled. They're not necessarily going systemically. So their issues are going to be more specified to the area that they're touching. Does that kind of make sense? Like they're traveling through those areas. They're not necessarily, in a way they're being distributed, but they're going more directly to the site than if you're taking them by mouth and they're being distributed to all of your cells. So when patients take these medications, these inhalers, they're prone to fungal infections of the mouth, which means we need to instruct them to rinse their mouth out after they use these inhalers, okay? We're not going to give them to patients who are allergic to steroids. We're not going to give them to patients with acute bronchospasms. Why? Yes, because they're long acting. They're not gonna work immediately. If they're having acute episodes, this is not our drug of choice. Now, if they are having acute episode after acute episode and they are just all the time, then they will be placed on this, but they will still have their rescue inhaler on top of that.
And a rescue inhaler is
albuterol or Ventolin, those short-acting first two classes that we talked about. All right. The leukotriene modifiers are the ones that last class I talked to y'all about, and their action is to decrease the formation of leukotrienes, and they inhibit leukotriene receptor sites. So leukotrienes are similar to histamines. I'm not going to give y'all a full A&P lesson on that. For all of y'all's purposes, similar type action, okay? They're used in prophylaxis, which means what? Come on. You don't know? Prevention. Prophylaxis is prevention. Prophylaxis is prevention. That's for sure a word y'all need to know. And treatment of chronic asthma in adults and children greater than 12. So this is a true story. I say true. I mean, it is a true story, but my daughter was placed on montelukast. That is the Singulair. She was placed on that when she was probably 4 when they put her on that. And so she was taking it. This was a few years ago, and she was taking it. And she was like having really bad dreams, like really, really bad dreams. And so, and it really wasn't working anyway. And we really didn't put the bad dreams together with the medication. Like she was just having like a lot of night terrors. And so we didn't but her medication wasn't working, and she ended up coming off the medication, and then she stopped having bad dreams. So we were like, oh, okay. Well, in recent years, like in the last year and a half, they have noted that those medications cause psychiatric disturbances in children less than 6. So those are things that the FDA approves them, but they don't link these things together. Like even as her mother, I didn't say, oh, she started taking this medication and she started having night terrors. I just thought she was 4 and she couldn't, you know what I'm saying? And she couldn't sleep. So these medications, I mean, unless your kid just absolutely can't breathe, benefit versus risk thing, they're no longer recommended in children less than 12 for that reason. That's crazy.
I took Singulair as a kid too.
Did you have a lot of bad dreams?
I did have a lot of bad dreams, and I stopped taking it like for a long time. I recently started back on it, and I've actually had I usually don't dream, and I've been having like weird, it's not like bad dreams, but vivid dreams.
But isn't that crazy? That's something that has no effect. But I mean, it took them years. I mean, that medication's been around for a long time, y'all.
Awesome, honestly.
Right. I mean, it didn't really work for her, but I've seen it work really well on a lot of people. But it took a long time, and that was probably never linked together for you as a child.
I just stopped taking it because, I don't know, I think it was like our insurance stopped covering it when I was like 13, and so we just stopped getting it. But then I was like, I literally have year-round allergies. Like, cannot stop sneezing. Doesn't matter what time of year it is. And I was like, man, I just asked my doctor, like, can I take this every year?
So yeah, but I just found that, like, when those studies came out, I was like, what? Because I mean, they were linking like really bad stuff, like suicides, like lots of psychiatric, a whole lot of stuff in children. It was really sad. So that's a fun fact. I mean, it's not so fun, but it's a fact. So they can cause headache and dizziness, GI problems, dyspepsia, respiratory reactions like flu-like symptoms and cough. All of these are kind of vague symptoms, honestly. All right, I'm not gonna go into any of that. So y'all have pretty much told me all this stuff. I'm just gonna touch on this stuff. This is stuff that I was asking y'all throughout. We're taking blood pressure, pulse, respiratory rate, right? We know why. We're noting dyspnea, cough. We're asking, is it phlegm? Is it colored? You know, we're bringing all of that stuff into play. Are their respirations noisy? If we say a patient is using accessory muscles, what does that mean? Accessory muscles, yes. Yes. So like when I'm breathing, I look like a normal person breathing, right? If I am,
Muscles that aren't usually.
let me get myself right. If I'm going, that's my accessory muscles. It doesn't usually take these muscles to breathe, right? So our stats might be okay. But if our patient is using those muscles and they're, especially in children, they're retracting on the side, they're sucking into their intercostal spaces. That made me lightheaded breathing like that. Like there's chairs on the floor. It's because she hyperventilated in class. If your patient is sitting like this and just trying to get more air, or you pay attention to their posture, pay attention to what they're doing. It's not just what your readings say. It's all of those other things. Let's see. Patients with and then like the general physical condition. So like everybody's asthma, when I'm saying asthma, I'm using that as kind of a blanket term. Those lower respiratory diseases, COPD, asthma, emphysema, those type things all together. So like let's just talk about my husband and my daughter again. When my daughter has asthma, she does not audibly wheeze. She gets a lot of phlegm in her throat initially, and she that's how it starts. She does not wheeze. When she is wheezing, she is like having an asthma attack. For her, it's see this general physical condition. She's her eyes get watery and really red underneath. And she just kind of loses. Remember I told y'all she's like a wild animal? She kind of just loses her, she just kind of loses that, and she just sits for a little bit. But she never says, Mommy, I can't breathe. But she deteriorates from her baseline, she deteriorates. When your patients start deteriorating from their baseline, notice those things before their SATs drop to the 70s. My husband, when he gets asthma, I can hear him wheezing, and I'm like, bruh, what is happening? Take her. And he's like, I don't feel that bad, but I can hear him wheezing out the door. But that's how different they present. So that's what it means by general physical condition. Patients with chronic asthma, you need to question the patient concerning their allergies. So like my daughter, y'all will be tired of me talking about it, but whenever I know she's having a lot of asthma at home, I go ahead and call the nurse at school and say, she'll know when she needs her inhaler, but like, don't call me. Don't send her home because she's got a cough. Like she's been using her asthma spray daily. Here's a heads up. Rather than her coming to her office and they think she's got the Rona, she's just got a little bit of asthma. You know what I'm saying? And so it's the same way when you're taking care of your patients in the hospital, if they tell you, I usually get really sick this time of year, my asthma starts to flare up, that is subjective data that you need to use and you need to keep in mind as you're caring for your patients. Ask them questions. How frequently have you been having attacks? How severe are they? What's working? Does it help if you just sit down a minute and get some fresh air? Or do you need to use your rescue inhaler? So assess the respiratory status every 4 hours, more often if needed. Record their eyes and nose. Observe the patient for effectiveness of the drug. Patients could have anxiety, ineffective airway clearance, impaired oral mucous membranes, or imbalanced nutrition. We want them to have an optimal response to therapy. We want to meet their needs, and we want them to understand and be compliant with their medication regimen. Patients taking sympathomimetics, we need to take great care in reading the primary healthcare order. Okay, so epinephrine, another word for epinephrine, y'all know, is adrenaline, right? So that is the utmost medication that we can use to increase that fight or flight response, to immediately open up the airway, to immediately get a response. That's like an EpiPen. So when our body goes into that anaphylactic state, we usually have bronchospasms, okay, which means our airways are closing. When we give the epinephrine, it opens them up, speeds everything up, opens everything up. But that's an emergent medication, okay? That's like the top of the top emergent medication.
So that's like the quickest. Like if you're gonna give it, that would be the quickest.
That would be the quickest. Yes, it's given IV in the hospital, and so like EpiPens are not generally given for asthma attacks. But like if you think about the most, like let's say my daughter had peanut butter, so she would swell up, but it would also affect her asthma. You know what I'm saying? Her airways would swell as well. So it would be like a multifaceted thing. If she was just having an asthma attack, I wouldn't give her a shot. But in the hospital, if you arrive to the hospital and you're having a major bronchospasm and your airways are closing, they will give you epinephrine IV. And these patients need to be monitored very, very, like basically continuously, every 5 minutes. Let's see. Salumedrol is not administered more frequently than twice a day. Most of the time, these medications, so long-acting inhalers are usually going to be given once a day or twice a day. Short-acting inhalers, usually Q4 to Q6, so anywhere from 6 to 4 times a day as needed. So patients taking xanthine derivatives for acute respiratory symptoms, rapid dealkalization using one of the xanthine derivatives may be required. Okay, so what that means is, remember that therapeutic thing I was telling you about? So, you know, in order for it to be effective, it has to be within that range. So when we say rapid dealkalization, we're going to give kind of a loading dose to get them to that range. Does that make sense? Rather than, oh, well, we need it to work, we need it to work. They might get a larger dose initially to get them to that hump to get it to start working. So these patients, if they're getting rapid dealkalization, then they need to be monitored for signs of toxicity. Very, very important. We need to report serum theophylline levels greater than 20 milligrams per mil or any symptoms associated with toxicity. And then we're going to monitor for hypotension, arrhythmias, and tachycardia. All right. These medications, the leukotriene receptor antagonist, we're going to give them either an hour before meals or 2 hours after because they interfere with digestion. Patients taking oral or inhalant corticosteroids, we need to administer it and wait a minute between puffs. Like if they're getting, we need to let them take one. We don't want to just go. We need to let them take one, rinse their mouth out. Let them take their next one, rinse their mouth out. We don't want to give a combination of all these drugs at the same time. All right, we're not going to worry about that. All right, and then I told you guys, anxiety is often associated with these medications because it's that fight or flight response. The body is kicking it into high gear. So we want to reassure the patient. We know your heart's beating a little faster. Okay, so think about what you would tell my Maddie. You would say, it's not, your shirt's not moving, your heart's not jumping out of your chest. We're going to just try to, that's that medicine is trying to make your asthma go away. So it's just making your heart work a little bit harder, but it'll calm down in just a minute. What is something that I could do for her to make her not think about her heart beating so fast that her shirt is moving? What? Distraction. Yes, distract these patients. Will we distract them by running down the block? No. Something calm, steady, television, something they can do with their hands, distract them. Distract them and reassure them. You need to be in a calm manner. So when my daughter is acting like a crazy person, I want to be like, sit down. You have got to sit down. You're driving crazy. But does that help her anxiety? No, she can't help it. She is 5 and she's going crazy. We need to be, as mother, as nurse, as whatever, we need to have a very calm front when our patients are anxious. So we've already kind of said all of this stuff. If their medications make them nauseous,